I think we'll start, guys. There's a few people at the other sites that have logged in. So today we're just going to talk about two cases. I call them challenging anesthesia cases. To remind everyone, this what we talk about here is for educational purposes and should be confidential. Not that it's particularly pertinent for my case. I call mine the long and winding road. It's very poetic. So I'm basically going to go over a case, look at the literature around it, and I have absolutely nothing to disclose. So this guy was seen in the pre-admission clinic. He's a 62-year-old male. It was for removal of hardware. His past medical history is fairly benign. He had mild depression, anxiety, and some mild reflux. About a year ago, he had gone for an ORIF of an acetabulum fracture. So he was working as a security guard, and a shoplifter pushed him over. He fractured his pelvis, poor guy. He is on a couple of meds, citalopram, amlodipine, ranitidine, ASA, no allergies. But one thing I noticed on the discharge form, which was completed from the orthopedics team, was kind of this vague description of ongoing chest pain with exertion, which was a little disconcerting. And when he was seen in the clinic, he very clearly said, "I have chest pain when I try to do anything active." Okay, that's a little bit concerning. Now, he had some of the titles have not translated well from Mac to PC, so just bear with me. It just says removal of hardware. You can see here he's got all this hardware on the left side of his hip, and they were going to take out a couple of these pins. So I dug deeper to see what was meant by this chest pain that was going on, and in fact he had seen cardiology back in 2015. He had exertional chest pain at that time, and he had undergone a stress test with one of our local cardiologists, and there was a little bit of upsloping on the ST depression. At that point they said, oh, maybe it's insignificant, maybe it's not. They kind of didn't do too much, but a few months later they decided to repeat the stress test because of the ongoing exertional chest pain. At that point in time, he had a repeat stress test, and it showed 2 millimeter upsloping ST depression in the inferior lateral leads. That was back in January of 2016, and bear in mind, his first surgery was probably in the spring of 2016. So this was before his first ORIF. Because of the upsloping, they said, okay, we'll go for a MIB scan. He went for a MIB scan, and it was perfectly normal. So they said, oh, well, it's probably nothing. Then he slipped, fell, he had a fracture. You can see on the left side, it's a little bit hard to see, but if you look closely, the head of the femur is basically just rammed right in, and that's all fractured all along there. So pretty extensive fracture. He was booked for an open ORIF of his acetabulum. It was a long procedure, but he seemed to do okay when I went over the anesthetic record. He seemed to do okay, and he went to the floor after, he went to rehab after, and then kind of went home, and that was that. But again, there was this kind of mentioning of, well, he has chest pain whenever he tries to exert himself. It wasn't completely investigated, and they just said, eh. So after, he was still having ongoing chest pain whenever he tried to do anything physical. He went back to see his cardiologist. The cardiologist said, well, you know, your MIB was negative. Maybe we should just wait, or we can potentially do two other things. We can do a CT angiogram, or we can go to the cath lab to see exactly what's going on. So they decided to pursue number 2, which is a CT angiogram. Now, unfortunately, it was done at St. Paul's Hospital, so I wasn't able to get a picture of the CT angiogram, but it translated into, here's the written document that I was able to get. And it showed, the impression was when they did the CT angiogram, there was a kinking of the ostium in the right coronary artery, but no atherosclerosis at that point. So there was a very obvious kink in the right coronary artery, very unusual to have that, but there was no per se lesion that could be attributed to atherosclerosis. And so nothing was done. So again, I don't have the actual copy of his, but basically on the ostium of his RCA, instead of it being This is the analogy I use. Instead of a nice tube that goes around, it was actually fairly kinked, sort of like this, to that obviously would have some consequences anytime you increase the demand on the heart. His heart didn't like it. Again, sorry about the translation from Mac to PC. So I decided to look into this and what is meant by this kinking and what should be done about it. So tortuous coronaries, so kinks in the coronaries are not unusual. They can happen in patients, particularly if you have atherosclerosis, you're a little bit older, hypertension. Mild tortuosity, it's very common as well, but not much is done about it. To have a non-atherosclerotic patient with angina, positive stress test, and negative angiography is very rare. So when I looked into the literature around it, of course it's extremely rare. There was a mention of arterial tortuosity syndrome, which is quite separate from what this guy has. It's a very rare genetic disorder. There's only been about 100 case reports of it. And you have this kind of corkscrew-like configuration of your arteries. It's associated with other blood vessel abnormalities, stenotic lesions, aneurysmal lesions, and it falls into that connective tissue disorder where you have quite a significant joint laxity and deformation and herniations throughout the body. So that's something completely separate from what this guy has, and extremely rare, so thankfully he didn't have that. But I did come across in the literature a few case studies that looked at patients with anginal complaints, abnormal stress tests, but no evidence of atherosclerotic lesions. And it's not hard to imagine that there can be consequences to having coronary tortuosity, because if you think of it as a garden hose and you're squeezing on one, you're kinking the hose, that can affect the downstream blood flow. And again, remind you, it's distinct from that very rare syndrome that I just mentioned. So they talked about 3 patients in this case study. The first patient was a 48-year-old male, pretty healthy guy. He had a positive stress test and went on to have some further studies. But at that point in time, they said, well, there's no definable atherosclerotic lesion, and we'll just treat him with medical management. When he went on to have his angiogram, you can see he's got these tortuosities in his arteries all throughout that they had noticed, which again, to have that significant tortuosity is quite unusual. The second patient, again, you can see that corkscrewing type picture of the tortuosities of the arterial, the coronaries. And this patient, she was a younger lady. She had 2 transplants before. She had exercise-induced chest pain. She went for her studies. They did show a reversible defect on the myocardial studies. She went for angiogram, and again, there was no fixed lesion that could be addressed, just mostly the tortuosity. Again, they chose to do medical management for her, as there was nothing truly that could be fixed. The third patient didn't have the angiogram picture to show you. He was a 51-year-old. Again, he was reasonably healthy, though he did have this history of testicular cancer that required surgery, chemotherapy. He went on to develop mediastinal teratoma that had to be excised, but other than that, he was reasonably healthy. He had an ECG that showed LVH, went on to have some further studies, normal echo. They did see a reversible defect on his MIB and went for angiography. Again, you saw that kind of kinking of the coronary arteries with extensive tortuosity, but no fixed atherosclerotic lesion. There was another case report that again touched on this idea of tortuosity and kinking of coronary arteries. This was from BMJ. It was a middle-aged lady with chest pain, positive stress test, was sent for angiography. And again, you see that kind of extreme kinking of her coronary arteries. In this case report, they did make some recommendations, again, based on an N of 1. So the evidence behind that, I guess, is just a collective agreement that it's very uncommon to have this level of extreme tortuosity. It can be picked up on angiograms. Mostly they're asymptomatic, and mostly you probably aren't going to do much. Given that, where would you even begin to address this kind of tortuosity? So going back to my guy that I saw in the clinic, I wasn't really sure what to do with somebody who had very clearly exertional chest pain and a kinking of his RCA. So I guess I'll open it up to the group to say, well, what would you do? Would you cancel surgery? But, then what? You could leave the hardware in. Technically, there was no source. It wasn't infected. It was just bothersome to him. You could call cardiology, proceed to surgery. So maybe I'll just open it up to the group to see what would you do given that you have this guy presenting with a known cardiac defect, very rare, not really much to go on in the literature. What would you do about it? Any ideas?
What did the cardiologist say after they got that report?
Well, yeah, that's what Tim. Yeah.
Just a question. I might have missed it in your initial history. Was there ever a troponin rise associated with any of these episodes of chest pain?
Not that I could have seen.
It seems odd that his MIBI test was negative.
Yeah.
Usually it's false negative if you have left main disease or if it's involving multi-segments of coronary arteries, but usually it's reasonably good. If you're just talking a focal, presumably right coronary lesion, I'm surprised it wouldn't have shown anything on the MIBI.
Yeah, I wonder too, though, it was a couple years before, the MIBI was a little bit older, and over those couple years it had progressed, so I'm not sure if that had, we were missing something that could, if we retested his MIBI, would we now see a little bit of a defect? A reversible defect.
A stepwise approach, and the first question I have is, do the cardiology experts believe that chest pain is ischemic? Because from the information you gave me, it's not entirely clear to me that they've actually hung their hat on that they said, yeah, this is definitely ischemic pain.
Yeah, so I was, like most of you are saying, we'll just call cardiology, which is what I did. I called the cardiologist to see if they could provide any insight to what to do with this guy and any recommendations. And he was, the cardiologist was kind of not really sure what to do because it's not something that happens. It's not something that they see very often, this kind of anatomical related ischemia. His recommendation, the cardiologist was like, well, don't make sure he doesn't exert his heart. Okay. But I just thought that was a bit odd. And I said, and I was talking to the patient about it, and he said, oh, it's okay. I'll be asleep. And that's, there's no stress on the heart. And I was like, well, that's not what happens when you go off to sleep. There's a lot of stress that can happen on the heart. Associated with tachycardia or whatnot from perioperatively. And the answer I got from the cardiologist was, well, just make sure, he doesn't overexert himself. Okay. That wasn't very helpful. And I think that's just because he honestly didn't know what to make of it. And it's not something that they were going to go and fix because of where it was. And I asked, would there be any benefit to, artificially taking away the stress from the heart with beta blockers or whatnot. And he said, well, I don't know. So basically the answer you wanted or the guidance you were hoping for was not very helpful. And I think that was just partially because, honestly, they didn't know what to do about it because it doesn't really happen to have these kind of non-atherosclerotic kinking that, especially in that ostium, which would be I think somebody was asking, you were asking, was there a trope rise? Not that I could see, but it's only been getting worse since that year ago. And I do think the cardiologists, from my understanding, is they did felt it was related to this, but they just didn't know how to fix it because it's not something that they could fix. And their recommendation was, well, keep him on aspirin and make sure he doesn't exert himself, which of course, is not what happens when you come for an operation. There's exertion involved. So I saw him in the clinic, and then lo and behold, as luck would have it, he presented in front of me, and so I had to deal with it. So I kind of used some common sense and said, well, we could, I had some beta blockers drawn up just in case his heart rate started to rise up. And we did it under a spinal because it was a removal of hardware. So I figured that would probably be the less invasive thing for him with respect to cardiac stress. The procedure itself, thankfully, is not the open reduction internal fixation, the big one that he had a year before. It was just removing a couple of pins. So what I did was I just did a spinal and tried to keep the cardiac demand low and the supply high. So I don't know if anyone would agree with that or would have done anything different, but that's what I did. Now the problem was, I don't know if anyone's been having this issue with some of the bupivacaine. Sometimes he's a very slim guy, very straightforward spinal, and of course the spinal didn't really work. So now I was thinking, well, okay, now what am I going to do? It was kind of sort of working, but not really. So there I was with, my plan A had gone not according to plan. So I was thinking, okay, well, I need to get him through this. So I was under the impression that it was working. It was just one of those really slow onset, offset that we've been having every now and then. So what I just gave him a little bit of, again, he's a very slim man, perfect airway. He was fasted. So I gave him a little bit of inhalation anesthetics just to get him over that first little bit of surgery, and then he seemed to have settled down. The spinal took, and then I turned off the inhalation, and that was that. I don't know if anyone had a better suggestion of what to do for that. Faisal? No? I don't know. That's what I did. Was it right? Was it wrong? Well, cardiac-wise, he did great, but then the spinal didn't work. Then he had urinary retention from the spinal, and he couldn't go home, and so it just became this snowballing kind of. You wanted it to be nice and.
Did it go up from the urinary retention?
Yeah, I know.
It may have down in the PACU, but he didn't complain of chest pain. So, I don't. Yeah, that's what I did, and sort of kind of worked. I don't know if anyone else.
Found another colleague to do his case.
Yeah, that's what I was hoping for when I saw him in the clinic. And then, karma came back, and there I was with him. So, as I had said, well, it seems reasonable to keep, a spinal would probably be the lesser of the two evils. And just to keep an eye on his heart rate. He was awake, so he could tell me if he's having any chest pain. I talked to him about sedation. And he was more than happy not to have it, and until, of course, the spinal didn't work, but that's what I did. Don't know if anyone else has thoughts, comments, concerns.
I think in the States, he might have a stress echo as part of his investigation. It's very hard to get one in Canada, but they have labs that do all sorts of stress echoes there, and you could presumably see if his RV was changing.
Truly, yeah.
I think that would probably be a useful investigation on this guy.
Yeah, I asked, should we redo his, when I called the cardiologist, should we it's been a year, more than a year, I think, since his last maybe, and his chest pain is kind of a little bit getting worse. Should we do any further testing? And he's like, the cardiologist said, yeah, we probably should. I'll see if I can get him in. And of course, they didn't. And so here I was with this guy that didn't.
I presume if he had a positive stress echo that his RV was doing something with exercise, and it's right at the coronary ostium where they can't really stent it without risk of blocking the whole thing off, I presume then he'd be a good candidate for a single vessel CABG.
For a single vessel, yeah.
Bypassing that kink, but I don't know. I've never seen this.
Yeah, well, I guess there was no optimal path, and just kind of had to get through it. But I worry about him as he gets older, that the chest pain is not going to go away, and then, will he eventually end up with a single vessel CABG? Anyhow, that was my case. I don't know if anyone else has questions, comments?
It just doesn't make sense to me that the cardiologist talks about avoiding cardiac stress
Aye.
but doesn't put him on a beta blocker.
Well, that was exactly my impression. There was a couple things I wasn't too sure about, but it would be reasonable to me that that would be a step to ensure some control over his cardiac demand, but they were not convinced that that was, for what reason, I don't know. There's nothing to go on other than common sense saying that this might help. Yeah, I agree with you, Roland. Anyways, I had some, in the room I just had some Esmolol and other beta blockers just in case that became the issue, whether cardiology agrees or not. Okay. I think Wendy has a case too she wanted to go over, if there's nothing else. Yeah, I was scrolling down.
Okay. Okay, so this is quite a different case. And I've tried to look at it. I looked back at the last M&Ms I did, and it related to respiratory issues as well. So I've obviously got a little bit of an obsession about this. This was what I found to be quite a challenging case to be done on a Saturday morning on the first day of the long weekend, which proved to be quite a chaotic weekend, and was interesting in that this case was done on a Saturday with no AA. I had a very similar case on the Monday, and Kyle arrived at work, which was fantastic. So one of the things I'd like to come out of this is yet again the importance of having adequate support staff when we're in the operating room. One of the things I thought we could do is just to take a perspective on M&Ms and look at, this is what they call a fishbone diagram, and you look at the issue, the outcome, and then look at all the contributing factors. So just if you have a quick look at this, the people involved, the place, the policies, and the procedures, thinking about that as we go through the case to see what contributed to this and how possibly we could change things in the future. So what do you say when the radiographer walks into the room and announces you've placed the NG in the patient's lungs? And as you can see here, this is the patient's NG in the right side of his chest, and that was one of the things we had to deal with. So the case reviewed is Mr. D.A.W. He's a 27-year-old male who presented on Saturday on the 2nd of September 2007 at 8 o'clock of the long weekend for an urgent laparotomy and decompression of a closed loop small bowel obstruction and probable release of adhesions. His history for this present event was a 2-day worsening of severe central intermittent abdominal pain with significant nausea and vomiting. His past medical history involved, and anesthetic concerns involved Vater syndrome, which I had to go back to the books to look up. And so Vater syndrome, just as a reminder, is a patient with vertebral defects, anal atresia, tracheoesophageal fistula, and renal anomalies. Now, what has happened, this has become, nowadays the correct wording is VACTERAL, which they've added cardiac defects and limb abnormalities to this. And it's called VACTERAL association because VACTERAL is not a syndrome, it's not a genetic, they actually don't know why it happens. So he actually still had Vater, not VACTERAL. His other issues was that he was completely deaf and mute, and he only signed with his foster parents who were wonderful. He had fetal alcohol syndrome. He had severe dysphagia and since he had had his tracheoesophageal fistula repaired, he'd had a GJ feeding tube since that time and had some issues with that. So it was a high aspiration risk, as well as his full stomach and his his bowel obstruction. He did suffer from severe GERD and was on omeprazole for that. He'd had a history of palpitations, which admitted him to the hospital, and he found to have a wide complex tachycardia. He was on treatment for that, hypertension, and then severe kyphoscoliosis with anticipated restrictive and obstructive lung problems. His past surgical history is a seen tracheoesophageal fistula repair as a child with a gastric pull-up. That's important. A repair of his anal atresia, thoracotomy for management of a pneumothorax, and a laparotomy for small bowel obstruction. It sounds as though he'd had a couple of those. So medications, he was on ramipril and verapamil for his hypertension and his wide complex tachycardia, and then the omeprazole. He was taking puffers. To what avail, I'm not sure. His caretakers said that they didn't feel it made a huge difference to him. And of note, he had not had any of his antihypertensives or his verapamil for the last 2 days. When he arrived in the pre-surgical area, he was curled up in bed, quite deformed, afebrile. He was communicating by signing with his family. His SATs were 96, blood pressure was stable, and pulse was 113. His airway, interestingly enough, he had a Mallampati 1, fortunately. His thyromental distance was adequate. His neck was very short and contorted, and he had significant limited range of motion of his neck. His abdomen was markedly distended for his size. He was only 54 kilograms, and it was tender, very tender, but soft to palpation with no apparent peritonism. He had decreased air entry at both his bases, no wheeze, and there was cardiac examination was unremarkable. So the only things on blood work were his white cell count was 15,000. His hemoglobin was 166. It had been quite a lot lower the previous year when he'd last been seen. He had a sinus tachycardia with an extreme right axis. His echo from a year ago was normal with no valvular abnormalities, and his Holter just showed a high resting heart rate. So his chest X-ray on admission showed this quite extensive kyphoscoliosis. But the thing that I had failed on this, initially looking at this X-ray, but appreciating is this air bubble in the top of his chest with a fluid level in it. And where I put the black arrow suggests that's what is his gastric pull-up. So he had a gastric pull-up that was full of fluid. This is the CT that of his chest at around just below the carina. So this was his right lung, his heart, and this here is his esophageal pull-up full of fluid, and then his aorta. So everything's completely distorted. His abdominal X-ray showed this massive air-filled, what they thought was a closed loop obstruction of small bowel, probably on the basis of adhesions. And it was very difficult. It's interesting reading the CT report is that none of his bowel organs were in the right place. Everything had been pulled around and changed. So anesthetic concerns are, as mentioned earlier, the aspiration risk of kyphoscoliosis, and then the issue with communication, dealing with a deaf and mute patient who is written up to in one consult as having had mental retardation, which was written by one of the older cardiologists. And so it was difficult to know what was I dealing with, how much did this young man understand. Anyway, his foster father was very, very helpful, and we got a fair amount of information from him. I think managed to convey to him what we were planning to do. And I explained to them that he would most likely be ventilated postoperatively, analgesia was going to be an issue, and obviously one of my biggest concerns initially was his high risk of aspiration. So as far as the anesthetic is concerned, we brought him into the room. I put him on the troop pillow, purely not so much for intubation positioning, but more to keep him head up. And then I tipped him feet down. One of my concerns with having him head up and feet down was that his hemoglobin was very high, and at this stage I think he was severely dehydrated, that he was going to crash on induction. Nevertheless, I thought it was more important that we actually have him well positioned to decrease his risk of aspiration on intubation. He was pre-oxygenated while I was doing the outline with high flow mask oxygen, and then I did a rapid sequence induction with a cricode pressure glide scope. I did not attempt to ventilate him, basically praying that he was intubatable, and intubated him not with a size 6.5 but a 7 tube. He desaturated, he crashed basically. His saturations dropped down to like in the 40s, and I auscultated, and I intubated his left mainstem. And at this stage, the endotracheal tube was at 19 centimeters at the teeth. I pulled back a centimeter and got air entry on both sides, but was still concerned because I had very little leeway and I did not want him to suddenly decompensate. He had very little reserve during the surgery. So I scoped him, and I could not find the right main bronchus. I was looking straight down the left main bronchus. The right chest was actually ventilating at this stage, and the SATs had come up. So I thought I need to know where the tip of the tube is. I tried pulling it back a little bit, still couldn't find the right main bronchus. But at this stage, I was concerned that my cuff was going to be coming out of through the cords. So I basically got a chest X-ray, which proved to be a very difficult thing on a Saturday. We had to wait half an hour because the radiographer was on his break. And anyway, we got the chest X-ray, and this is basically, it's hard to see, but you can see here that the tip of the tube and the corona is right here. And what's interesting, well, that I thought, well, I'm in a good, reasonable position, so I pulled back another centimeter. Then I looked from above with a guide scope, and his cuff was right at the cords. We proceeded on. He was ventilating well, and actually his compliance was not as bad as I thought it would be. I ran him on a lido infusion, ketamine intermittently, and hydromorphone. And during the middle of the surgery, Connie asked for a nasogastric tube, which I thought was a bit of a scary thing to be doing, considering that we didn't really know what his anatomy was like. So I placed the nasogastric tube with a laryngoscope and gently passed it, and it got to a point at 25 centimeters where it would not go any further, and I did not want to push further. So at the end of the case, I chose to do an abdominal X-ray just to see what the placement was. We were draining significant amounts of nasogastric contents. So clearly we were in something, but I didn't know what. So this was the X-ray you saw at the beginning, what we saw when we did that post-op X-ray. At this stage, it was now what do? We have a young man who we know has severe reflux. We know he's going to be, well, at that stage, I thought he was going to be ventilated. And Connie said, no, just take it out and we'll put a gastric tube through his gastrostomy, his feeding gastrostomy, and we'll drain him that way. So I proceeded to take that out. The end of the case, we were waiting for the RTs and PACU to set up for ventilation. And during that time, he had been breathing spontaneously for quite a while at that stage, for probably about half an hour. He started emerging and became quite agitated because he was wide awake, breathing really well. SATs on 80% were good. And I thought, well, now what do I do? Do I extubate him or do I take him back? We had no problems ventilating him, but he's still this high aspiration risk. So I thought, well, if we extubate him, he's got to be wide awake. So we wait until he was completely wide awake, but now he was not coping to having the tube in situ. And Jay, who very insightfully said to me, "Oh, why don't we get his mum in to come and sign to him?" And that's what we did. We brought her into the operating room, and she signed to him, and he said he was comfortable, he had no pain, he was certainly compos mentis, and we decided to extubate him there. And we took him to the PACU extubated. We ran him there on a lighter infusion, and originally I'd arranged with HAU or ICU that we would send him to the ICU if he was ventilated, or HAU if he wasn't, and we'd run him on a hydromorph infusion, because I didn't think at that stage that he'd be able to manage PCA. Anyway, with very dedicated staff in the PACU, they got both the parents in, and they started communicating, and it turned out that he completely understood what needed to be done, and he used PCA. He did extremely well, a lot better than I'd anticipated. In the recovery room, we kept him at least 30 degrees head up, and he was transferred to the HAU. He spent about 3 days in the HAU, and unfortunately, 5 days post-operatively. And Paddy, I think you might have been involved with him, his care. He'd been sent up to the ward, and this is one of the problems, is this whole resource issue, what we do with complex patients. He was just sent up to the ward. It sounds like there was a combination of possible aspiration, 5 days post-op, and fluid overload. So I don't know which played the biggest part, but probably the fluid overload, because 2 days later he was extubated and he's back on the ward again. So this is a complicated problem with an outcome that I would say, could our care management have changed his outcome had we had different access to resources, to to HAU type care for this young man for a longer period of time. What I throw out to you is, what would you do in a situation where you've got this abnormal anatomy? Should I have left him intubated and waited for, I'm not sure what, allowed him to be ventilated for a number of days, or was it okay to extubate him when we did? And what do we do about somebody who you know is an aspiration risk? Do you keep them intubated for that reason only? I'm not sure. We would have had to keep him heavily sedated if we'd done that. So my take on this was a complicated situation. We're doing these kind of cases regularly, well, all the time at the Columbian, and I would like to speak to Dean Jones and to administration to say that this is yet another case in amongst thousands of cases we do after hours and during the day and at nighttime, where we need adequate assistance. This particular day we were short of nursing staff. We had no unit clerk. We had no AA. There was nobody around. It was frantic in the OR, and this is the kind of case we're taking care of. I think we need administration to take note of the fact that this is not an ordinary hospital and needs to be resourced adequately. Anyway, so I'll throw it open to you. What do you think?
I'll just say from my point of view, like I had a heads up from Connie that he was deteriorating because I was nights that night. And so when I came in, Sheila Webster was on, and so we read your note, which was very helpful. And I said, because Connie had told me she was difficult intubation, and then I read your note and I said, and actually Rob Sharp was on, and he knew too. So
complex
said,
intubation.
No. So we, Sheila and I got together and we looked at him, and he was on. They brought him down on BiPAP, but he was clearly kind of starting to fade. And so, first thing we did, we went and looked at all our different endotracheal tubes and see if we could find one that was shorter, distal to the cup, right? So that was the first thing, because we felt we had some time. And, because I brought out everything we had to see if there's anything distal, that was a bit shorter distally. And, we settled on the 7 because if you go up to a 7.5,
It's
it
longer.
gets longer. So we settled on the 7, and then, we settled on the fact that, so they got, RT brought all the bronchoscopy equipment up so that Sheila could bronch him afterwards and, place the tube in the appropriate place, and maybe, place the Murphy eye over that so
Yeah.
she could actually place it properly. So your notes were very helpful.
Oh, good.
We had some time, so we kind of made a plan.
So, just of interest,
all
because
the
I
people
felt
around.
quite bad when I went to follow up and see that he'd actually been re-intubated, and I did not dictate a consult on him because the day was so crazy, and by the time I got home, and I'm still thinking that I should probably do that in hindsight because he is a complicated patient and be nice for down the road. So that was one thing. But where did you get my information? Did you go to my anesthetic record?
Yeah.
Because that's one of the problems with those anesthetic records not going straight to the EMR as well. Another policy issue that they're not having that go straight through is that it's not always easy to find people's anesthetic records on patients who are inpatients, and these are the patients we need the anesthetic record on often.
Yeah, no, I mean, I know I had time, so I went through the chart and found the anesthetic record, and like I said, Sheila and I sat down and talked about what we would do, what were the issues.
Yeah.
I said the issue is he's got a short takeoff, so we need the shortest tube. So we had some time, and as you said, he's a straightforward intubation.
Yeah.
And then I left them to manipulate the tube because I had.
Well, it's interesting, if you look at the CT they did after he'd been re-intubated, the tip of the tube is touching the carina, basically.
I don't think you have much option. Right?
Yeah.
So the interesting thing is that, maybe at Children's they have smaller tube, different tube types.
Well, I
don't
thought
know.
about should I have used a 6.5. I didn't
Well, I got
realize that was.
6.5, it's the same length I measured.
Oh,
them.
okay.
And the other thing, Sheila said that she has a patient similar to that who has a trach, who they've had a custom-made trach for that patient that's got a shorter post-cuff size. So, but I'm wondering if places like Children's who deal with more of these anomalies might have different size tubes. I don't know whether there's other things out there, and that would be something to explore. I don't know.
Something I did learn at Children's with a couple of these kids with that really early right stem takeoff is where the Murphy eye is, there is a tool. I don't know if it's bone cutters, but you squeeze them and it's like it shells it out.
Oh.
You can actually cut the Murphy eye larger.
Oh.
You don't
I
want
guess
to
we
cut
could have
the
done that
end
with
of
it
the
here.
tracheal tube because it's sharp.
Yeah.
Cut it.
Right. Oh, so
So
it's
you
like a
can
punch.
make the Murphy eye bigger underneath the cup, which gives you more playroom
Yeah.
for that right main
So you need like a punch.
I have to say, looking at this at the time, I had not anticipated. Was more concerned about aspiration. I was concerned that with the tracheoesophageal fistula repair that he may have some stricture or narrowing. So I actually had a 6 and a 6.5. But the fact that I had this really right-angled right main bronchus takeoff was not something I'd anticipated, and I don't read enough CTs as Faisal noticed the other day to actually have picked that up preoperatively. This was something I just came across from as well.
I'm just wondering, what was your concern with leaving in the nasogastric tube, knowing that there was that air fluid level high in the chest? Because if they're draining from here, is that going to be effective up here? And was there a risk to leaving in the NG tube? Or?
Well, post-operatively, it was a question I asked because we kept him, we'd obviously drained him, and his post-op chest x-ray looked much better. And I unfortunately I don't think I put it on. But the post-op chest x-ray just had air. So we had drained all the fluid for that time, but clearly it keeps reaccumulating. And I looked with hindsight and looking what happened, I'm thinking it might have been a good idea. The problem with that tube is it was sitting at right angles. And I don't know about erosion. They're quite hard tubes. It's sitting in the chest. Connie was not keen to keep it in, and she thought we could drain him from below, which clearly we didn't do, because if you look at his serial chest x-rays after during his time in HAU, he fills up again. So this must be an ongoing issue, but he sleeps sitting up too.
That's part of his
Yeah.
original stomach in his chest, right?
Yeah. So, yeah.
You guys were happy then, like on that chest x-ray, that the nasogastric tube just turned right because of his kyphoscoliosis and that aneurysmal sort of
Well,
esophagus.
you saw that. Let me just see if I can. or is it CT?
Yeah, so sure.
Yeah, so basically you can see from this here is his gastric pull-up. And this goes right up to the level of his carina. It's this massive dilated thing. And some of the CTs, I didn't, unfortunately, there's a really nice picture of him the second time round where they've got him lying flat and there's an air fluid level across this gastric pull-up area. So it's a huge structure that's sitting in his right chest, and you can just, I think, vaguely see it on one of these chest x-rays.
If you talking about the radiologist saying that the NG tube was in the lungs, is that what they?
Oh no, they're not the radiologist, the radiographer.
Okay.
The radiographer came running into the room. He said, "Oh, you've put it in the lungs. You've put it in the lungs." And I'm like, "Well, I know it's in a viscous of some sort because it's draining fluid." But yeah, he was quite beside himself. So yeah, had it not been draining nasogastric fluid. And also having seen the CTs ahead of time, I knew he had, I didn't quite know and understand what it was, but looking at the CTs in more detail now post-operatively, I appreciate what I was dealing with. But at the time, you're going through this and trying to get the case going. And yeah, I think, in hindsight, what I would have done is I would have left that in situ. The problem is his aspiration and his fluid overload occurred 5 days post-op. So he did really well for the first 2 days when I went to see him both days. And they'd kept him, I asked strict instructions to keep him sitting up. And, on the ward, the problem is patients, anything can happen on the ward. So it might have been accumulation of fluid, excessive fluid. During the case, I supported him rather than so I gave him a liter, 1,300 mils of fluid raw and supported him with inotropes rather than actually give him a lot of fluid to resuscitate him. So,
question, so Connie wanted to retrogradely drain so there's a feeding gastrostomy tube as well?
Yeah, so he had a feeding gastrostomy tube that had another tube through it that was supposedly a gastrojejunostomy feeding tube, but the actual feeding gastrostomy tube, and it's not that easy to see it on here. Some of the pictures you can see it. We don't know because his anatomy is so distorted. He has small bowel in his right upper quadrant, and his large bowel, that's his cecum, is actually in his right upper quadrant, and his small bowel is all sitting in his left side of his abdomen. So nothing is normal.
Where's the stoma?
The stoma was on the right side. So who knows what it's going into, and he's had so many surgeries with.
Yeah, I think. For them to drain that, they'd probably have to guide it under fluoro, retrogradely into the thorax.
That was one of the things I was suggesting to Connie is, should we have sent him down to radiology to have a thinner catheter put into that gastrostomy pull-up, the gastric pull-up in his chest to drain him while he was healing.
Yeah, ideally, because you were so worried about induction, someone would have actually, small bowel obstruction, it's nice to decompress them before you induce them, especially when the stomach is in the thorax. And ideally,
and it's full of fluid.
And ideally, I don't know, they coordinated with us. Really, how would it be to actually drain that before you have the pain of inducing it? So
yeah, in hindsight, I look at it and I think, should I have tried to put a nasogastric tube in before I induced him? Which I'm not sure that with the difficulty that I had putting it in with him asleep.
With his parents there and.
Yeah, it would have been very challenging, and I think it's there by the grace of God, Guy, that he didn't aspirate, and there was no fluid there on induction. But
Wendy, I think you did a great job, and I would have extubated him too in that situation. Patients aspirate all the time in the ICU, intubated, so it's not a guarantee leaving him intubated would prevent that.
Yeah.
But I want to further where Michael was going with the conversation. Pre-op, how many days was he in hospital pre-op?
Less than 24 hours. He came in on the afternoon of the 1st, and The reason they did him urgently, because I said, well, he's not got peritonism, he hasn't ruptured, and Connie's saying, and I think she was quite right, when we opened up and saw what we were dealing with, the risk of rupture, this viscous was, well, you can see from that CT of his abdomen, it was really distended, and the areas where it was pinched off, I mean, those looked like they were paper thin. So, I mean, if he had ruptured, I think it would have been a very different story. And just like the guy we had on Monday, who was another severe kyphoscoliosis, but this guy was mentally challenged. And so he was and he was really sick. He had ruptured, and it was the same all over, but sicker.
I knew of this case only because I was nights on the first, and sadly had to hand that case off to you first thing Saturday morning.
Thank you.
I mean, there was all this talk about this guy and all these things, and lots of kind of considerations, but it does present the reality that as these children survive into adulthood more and more, because they do such a fantastic job to manage them as pediatric patients, we're very likely to see this more frequently in the next 20 years, whoever's practicing.
Yeah.
So I don't know, I mean, when somebody says Bacterol or Vader, it brings you back to some faint memory in medical school.
Yeah.
Having it rounds like this is extremely helpful. Thanks for the summary.
For me, one of the things, I think this is exactly when I was going through all this, and there wasn't a lot of information on our chart, on our EMR, is there should be some kind of, with these complex patients, some kind of handover consult that comes from children's to the area that the patients are being cared for, because they come with no information. I mean, his foster parents were completely amazing. They're both retired nursing staff from VGH. So without them, this case would have been a very different situation, and I think he would have been ventilated. But they were remarkable.
We're just seeing now that we're now finally getting provincial sharing of all imaging, that we're now going to be able to get all the different health authorities. The dream one day would be that all medical records are equally available, because when you're at a tertiary quaternary referral center, the challenge to find information, like reliable information, is extremely difficult. In 2017, it's unbelievable that it is that way. So.
Yeah.
Speaking of medical records, so what is the reason why our anesthetic records don't appear in Meditech for?
They're not.
They
haven't linked it. They still scan them, so they only get scanned in after the patient's discharged. So in order to access an anesthetic record, you have to go to AIMS, and you can log in for the day that anesthesiologist and just put their name in and find the case. And I've done that a few times, and it's very useful, but it would be way easier if they just went straight to Meditech. But
the only way you can do that is from an operating room computer.
Yeah, but I think that, I don't know that Meditech and AIMS speak to each other, which makes a lot of sense in Fraser Health.
The other thing is it'd be more accurate too, right? Because I find sometimes I'm all ready to go, I do, patient out of the room, and then I realize, oh no, PACU's got a hole up, and then I put the monitors back on and all that sort of stuff. But all that isn't included because I've already sent the paper trail. And
you can open it up again if you want to, yeah.
You could,
but
I mean,
it doesn't show anything. So, but it's not really the final copy.
No, you're right.
Record.
Yeah, it's. But we seem to be doing major workarounds. I'm not sure. I think Susan has been looking at the electronic anesthetic record from Toronto, that looks more promising from a point of view of being able to be integrated and to get data from. But the problem with this is that I actually quite like using the record, because you can do, as Patty said, you can make documentation about what's gone on and which is much, much more thorough than I ever used to do with a paper record. But the problem is that information is not being used. So while it's great in one respect, it's really lousy in another. So it's all these system issues, and hopefully one day when I'm dead and gone, it'll be sorted out.
Hopefully soon.